Good evening, everyone. Today we'll discuss how to manage a patient with thalassemia. If a lady with thalassemia, she want to get pregnant, what to do preconception counseling, and if she got pregnant, how to manage her antenatal care, postnatal care, and all, and what are the different investigations to be done. So we'll discuss that. Okay. So first, thalassemia. So thalassemia is it's a central fault in thalassemia generally is reduced globin chain synthesis. So the globin chain synthesis will be reduced. So in beta thalassemia with excess faulty alpha chains, and alpha in alpha thalassemia with excess of faulty beta chains. Okay. So basically there is reduced globin chains, like beta chains are reduced in beta thalassemia, and there is faulty alpha chains, and in alpha thalassemia also alpha globin chains will be reduced with excess faulty beta chains are present. So these kind of changes occur in the red cells with insufficient hemoglobin levels. So ineffective red cell production results in release of damaged RBCs into the peripheral circulation with consequent extravascular hemolysis. So in alpha thalassemia, one faulty gene causes few symptoms, two faulty gene results in mild anemia, three faulty genes results in hemoglobin H, which results in blood transfusion dependent chronic anemia, and typical results in fetal death in utero. Okay, so basically, if you have damage, these globulin chains are reduced, then there is damaged RBCs which are produced and they are released into the peripheral circulation. If only one gene is defective, then few symptoms are present. If two faulty genes are present, mild anemia. If three faulty genes are present, then it results in hemoglobin H condition. What is that? Hemoglobin H condition. If there is hemoglobin H condition in a lady, she is depend on blood transfusion and results in chronic anemia. And if she get pregnant, then the fetus will have a growth restriction or fetal death in utero occurs. So beta thalassemia. Beta thalassemia is a consequence of reduced beta globulin chain production with related to overproduction of faulty non-functional alpha globulin chains. So you understood. So there is reduced beta chains. So why the name beta thalassemia? Because there is reduced beta chains, but faulty alpha chains. Okay, so the non-functional alpha globulin chains predict the clinical presentation. So beta naught is no beta chains, beta plus is few beta chains than normal. So if there is beta naught, there is zero beta chains. If beta plus means few beta chains are present. Okay, coming to trait, intermediate, and major. Trait or minor is when the person lacks symptoms. Apart from mild anemia will be present, but trait is generally then the other person have thalassemia, but they have they lack symptoms. Thalassemia intermediate varies in its clinical presentation, but usually associated with moderate or chronic anemia. Thalassemia major usually present within first 2 years of life. Most children with severe beta thalassemia major present in first 3 to 6 months of life when the switch from hemoglobin F to adult hemoglobin occurs. Less severe form may present later with severe anemia, poor growth and skeletal abnormalities during infancy. Affected children will require regular lifelong blood transfusion. So generally, if there is thalassemia major, so they generally present in within 3 to 6 months, where the fetus have hemoglobin F. Generally, hemoglobin F is there. It get converted into hemoglobin A. So once the hemoglobin A is start producing, then the symptoms will appear. So the baby who is a toddler will have multiple blood transfusion. Okay, the lifelong blood transfusions will be present in thalassemia major. Complications in thalassemia. So depending on the type and severity of thalassemia, iron overload can occur, leaving iron deposits away from the liver, the storage site for liver iron in endocrine organs, and heart also the risk increases. And so in thalassemia what happens means because of iron overload or because of multiple transfusion, the iron generally deposits in liver, but in thalassemia because there is excess iron, it gets deposited in other endocrine organs or other organs like splenism, endocrine organs. Deposition of iron results in diabetes, delayed puberty, hypogonadotropic hypogonadism, hypoparathyroidism. Rarely there is restricted growth and adrenal insufficiency. Coming to heart, there is arrhythmias, heart failure, pulmonary hypertension. Coming to liver, there is hepatitis, fibrosis, cirrhosis. The iron get deposited on the joints, results in joint pains and osteoporosis. So approximately 40%, how much? Approximately 40% of the adults, 40% of the adults with thalassemia are hypogonadal. 50% of them have more than one endocrinopathy, and hypogonadism occurs because pituitary iron overload, which is the most common endocrinopathy. Okay. So because of pituitary overload, there will be hypogonadism. So this is a thing where preconception, if a lady has thalassemia and she came to your clinic for preconception counseling, then what to do? First, genetic counseling you will do, whether the partner is also having thalassemia or not. Okay, so partner screening, patient genotype should be done. So patient genotype is also done. Pre-implantation genetic testing or prenatal testing for appropriate couples should be done. Fertility unit assessment. Evaluate both patient and the partner, including tubal patency, sperm count, hormonal assessment. You will evaluate this because if she came for fertility assessment. Contraception. If she is not planning for pregnancy, adequate contraception can be given. In all the contraceptions are safe in thalassemia. Coming to psychological assessment, you should evaluate the patient and the partner, and you should encourage smoking cessation because it's an overall thing, right? Coming to iron chelation is generally you optimize the iron chelation, change the iron chelation regimen to avoid DFP or DFX within 3 months of planned conception. So desferoxamine is safe. Others are not safe. Okay, so we should see serum ferritin levels. Target should be 1000 micrograms per liter. You should keep the target of 1000 micrograms per liter. Transfusion. Increased red cell requirements in transfusion dependent thalassemia patient is there. So consider transfusion in non-transfusion dependent patient. So ensure extended red cell phenotype or genotype before transfusion. You should extensively match the blood, and RH and KEL matched units should be used in both transfusion dependent and non-transfusion. So basically this RH typing and KEL matching should be done both in transfusion dependent and non-transfusion dependent patient. Both should be matched. Okay. Then target hemoglobin during pregnancy. If a patient came with thalassemia, her hemoglobin should be 10. So 10 is the hemoglobin or target hemoglobin for thalassemia patient. So this is the same thing, and this is the thing that desferoxamine is safe, DFO, desferriprone, and desferasirox. Desferriprone, desferasirox. These are not safe in pregnancy. Desferriprone and desferasirox. Okay. So yeah, iron chelation. You should change the chelation regimen to avoid avoid within 6 to 12 weeks. You should change the, if she's taking DFP or DFX, you should change at least 6 to 12 weeks before conception. Okay, that is very important. Okay, coming to cardiac, ECG, echo, cardiac T2 scan, Holter monitoring. If there is history of palpitations, then you should go for Holter monitoring. Cardiac T2 scan you'll do, na? In that cardiac T2 scan, generally the value should be more than 20 ms. Okay, it should be present. This is the target, and the ejection fraction of the heart should be more than equal to 56 percentage. Okay, 56 percentage should be the ejection fraction. Coming to liver, ferritin, liver R2 T2 scan, ultrasound liver for gallstone should be done, and liver iron concentration should be less than 7. Okay, heart is very big one, na? So heart have more than 20, whereas liver is compared to heart, it is okay, manageable. So it should be less than 7. Okay, so liver is less than 7, heart should be more than 20. Coming to endocrine, infections. You should assess the hepatitis B, C, HIV infection. Okay, you should monitor the hepatitis B antibody titers. Okay, offer immunization for who didn't take immunization. Ensure splenectomized patients, mainly splenectomized patients should have fully immunized. Offer HPV vaccine also. Okay, so nowadays HPV vaccine is also being encouraged to the thalassemia patient. Endocrine, glucose tolerance test, fructosamine test, thyroid function, DEXA scan, vitamin D, adrenal function, and you should ensure that calcium and vitamin D intake is good. Fructosamine should be less than 300 for more than 3 months prior to conception. So 3, fructosamine 3. Remember like that. Fructosamine 3. Okay, it should be less than 300. Fructosamine should be less for more than 3 months. Then that person is very safe to go for pregnancy. Medication session, if she is taking bisphosphonates, AC inhibitors, you should stop. Obviously, you'll commence 5 milligram of folic acid. Okay, this is one of the criteria where we'll give 5 milligram folic acid. Okay, so 5 milligram folic acid, ensure patient on desferoxamine are taking vitamin C also. So splenectomized patient should have penicillin prophylaxis and initiate aspirin also. Okay, so this is the same thing which I told you in the table. So basically HbA1c is not a reliable marker because glycemic control is not there, as the blood is being blood transfusion occur and blood get diluted. So HbA1c is not a good marker. Go for fructosamine. Okay. Preconception optimization. Well-chelated patients have equipped pregnancy outcome to patients with a thalassemia syndrome. So chelation should be induced outside pregnancy. They include desferoxamine, defiperipone, defersirox. Okay, this can be used in monotherapy regimen or two combined chelation therapy can also be given. Mainly the DFO, that is desferoxamine, is the only agent that has been used safely in the woman prior to the pregnancy. And if in pregnancy they want to give for chelation in pregnancy, then it is safe in second and third trimester. Okay, so basically they are saying that in first trimester you should not use any chelation therapy. In first trimester, no chelation therapy is safe. Okay, so other DFP, DFX, these are there. They can be switched to desferoxamine, ideally 6 to 12 weeks prior to conception. So transfusion dependent patients. So basically, you'll make the cardiac T2 more than 20 milliseconds and liver iron below 7. Ideally, you'll keep, and which I already told. And the inflammatory markers like NT-proBNP is there. It will be raised in thalassemia patient, but we cannot differentiate between the patients with cardiac iron or without cardiac iron. So we can't differentiate whether anti-proBNP, because in both the cases anti-proBNP will be raised. Okay. Worsening iron overload due to cessation of chelation, because we stopped chelation, so iron will be more increased in the body, and also the transfusions are going on and on. So there is risk of cardiac decompensation, new onset arrhythmias, complications of pregnancy. Okay, complications of pregnancy, new endocrinopathies, worsening bone health, liver decompensation. These can be occurred because continuously there is iron overload, there is no chelation. Okay. Preconception optimization. So most patients are fertile, generally have no thalassemia related complications. So basically a thalassemia female can get pregnant, they're fertile. So some patients can get iron overload because of iron increased iron absorption and intermediate transmission. There is iron overload, so it results in endocrinopathies. So red cell genotype, phenotype should be documented, reviewed, as is any previous antibodies that may increase the risk of transfusion related complications during pregnancy. Pregnancy in the patients who have received allogenic stem cell transplant. So if a patient, thalassemia patient who got stem cell transplant, what to do? If she want to get pregnant, what? So you should counsel regard the risk of fertility. When you go for stem cell transplant, risk of fertility will be there. So you'll refer her to fertility services and support her fertility preservation. Oocyte vitrification, embryo cryopreservation, ovarian tissue cryopreservations are options. So before going for allogenic stem cell transplantation, we'll go for this cryopreservations and all. Then you'll proceed for allogenic stem cell transplantation. In case of male thalassemia patients, semen cryopreservation is only available those who attain puberty prior to transplant. So if a 6 months old male, you can't semen cryopreserve, right? So if that boy already attained puberty, then you can go for semen cryopreservation. Testicular tissue preservation is being explored. It is not a complete studied kind of thing. Diabetes, thyroid dysfunction may occur as a late effects post stem cell transplant. So patients should be screened for these special late side effects in the clinic. So if you underwent this stem cell transplant, so this diabetes, thyroid dysfunction can occur. So you should come to follow up in the clinic. Assessment and management of patient with hypogonadism and needing spermatogenesis induction. So basically a patient with thalassemia, gonadal status should be assessed, okay, at the age of puberty, and also pediatric endocrinologist should keep in mind that, okay, this boy is coming to puberty age, so gonadal status should be assessed. Endocrine assessment can be done by FSH, LH, testosterone, inhibin B and AMH should be measured at baseline. And secretion of testosterone is generally diurnal, so you'll generally go for fasting testosterone test mainly at 8 a.m. to 10 a.m. Other pituitary function can be assessed, which are uncommon, but you can also go for that, like 9 a.m. cortisol, TSH, FT4, and IGF-1. These should be measured. Total testosterone, if it is less than 8, that means hypogonadism. Patient is going towards hypogonadism. If it is 8 to 12, then it means it is borderline. Okay, so 8 to 12 is also borderline. They should come to follow. If it is less than 8 means already the gonadal dysfunction started in the male kid. Okay. How to induce? Some people they'll have delayed puberty. Okay, how to induce puberty? Because there is hypogonadotropic hypogonadism. So how to induce puberty? So induction of puberty usually gonadotropin therapy may result in improved testicular growth and initiation of spermatogenesis. So once testicular volume has been maximized, semen analysis undertaken and consideration taken of option of sperm banking, gonadotropin therapy should be withdrawn and gonadal status reassessed. Testosterone replacement therapy can be initiated as necessary until fertility is desired. You understand? So once the male kid attain the puberty, induction but at not attain puberty, there is delayed puberty, then you can go for gonadotropin therapy. Okay, they'll give FSH LH type kind of therapy to that male kid. So the testicular growth will be increased and there is initiation of spermatogenesis. Okay, there is initiation of spermatogenesis. How you will know? You will go for semen analysis and you'll see all the test reports are good. Then you also go for option of sperm banking. The sperms are good because it can revert back. So whatever you did induction of puberty and you got sperms, you go for sperm banking. Okay. Again, after gonadotropin withdrawal, you'll go for gonadal assessment. Again, you'll see the testis size and all. To maintain the testis size until fertility, you'll give testosterone replacement therapy. What is the induction of spermatogenesis? So I told you LH you'll give which stimulates the testosterone production in lady cells. Okay, HCG hormone has a LH equivalent, so it is used therapeutically as a LH equivalent due to its longer half-life. So you can give LH or you can also go for HCG hormone. Okay, so HCG is a patient administered subcutaneously. Patient self they can administer self like insulin only at the dose of 1500 to 2500 units twice or thrice weekly. So in a week, they'll apply at least twice or thrice weekly. Okay. Blood tests to be monitored. You'll monitor the levels of testosterone every 1 to 3 months. You'll measure the testosterone. If they're subnormal or supernormal, if there is high also, you'll adjust the dose accordingly. Serum estrogen levels also increases. Okay, so during HCG therapy, estrogen also increases. So there will be breast tenderness in a minority of the patient. So consideration should be given to add aromatase inhibitors in this patient. Letrozole can be added. Okay, letrozole can be added because serum estrogen levels will be increased in these patients. Okay. The HCG can increase estrogen levels also. So estrogen can increase estrogen levels also. So that can result in breast tenderness in some patients. So you will give aromatase inhibitors in them. Once normal values are achieved, some semen analysis should be performed every 2 to 3 months. You will measure the semen analysis. In this way, you will actually induce puberty in a thalassemia patient who has delayed puberty. Okay. You'll add FSH equivalent also. If azoospermia persists, you did everything. You gave LH, you gave HCG. Even then, after doing some analysis, the azoospermia is seen in after 6 months also. Even the testosterone levels are normal. Even then, there are no sperms in the semen, or there are less sperms in the semen. Okay, at that time, you can give FSH. Okay, generally 75 units 3 times weekly is given FSH. Subsequently, you will achieve physiological serum FSH levels. Okay, so you'll give FSH and you'll measure the serum FSH levels physiologically. It should be present 4 to 8 in a male. Okay, so you'll maintain that. Doses can be titrated at 75 to 150, 300, maximum 300 you can give. Okay. Consider adding FSH at the start of HCG therapy. When you will give HCG therapy only, no, you can give FSH at that time only who have incomplete or absent puberty. How do we know whether they are having puberty or not? So by means of 12 or 13 years of age, the male person should have been developed the secondary sexual characters like increase in the testis volume, increase in the penis size, the hair, secondary sexual characters, the hair on the upper philtrum, okay, on the chest, pubic area. These should be present. If these are absent, means there is or if they are minimal, that means there is delayed or absent puberty. At that time, you will start that HCG, or these are telling that you can start HCG plus FSH combination therapy. Okay, whatever treatment you will do, how to check whether it is working or not? Every 3 months you will go for semen analysis. Okay, patient remaining azoospermic after 24 months of combined therapy, unlike to respond to continued gonadal therapy, can be considered for microsurgical test, that is testicular sperm extraction can be done. Okay, if the sperms are present in the testis, you will extract and you will go for sperm bank. Otherwise, gonadotropin therapy can be withdrawn and testosterone replacement therapy can be recommended. Okay, so once the semen analyses are good, you should maintain that with testosterone replacement therapy. Okay, coming to females, if a female came with thalassemia came with infertility, how to go for ovulation induction? It is generally like the normal. Okay, how you will do ovulation induction normal? You will come, the patient will be coming, you will go for baseline transvaginal ultrasound, you will assess the pelvis, you will see endometrium, whether it is less than 4 mm and no follicle is more than 10 mm, then you will go for ovulation induction. Okay, this is the, say endometrium is less than 4 mm and no follicle is more than 10 mm at the time of day 14 of 28 day cycle. Okay, in that way. At the time of ovulation, this is the picture. That means there is no ovulation. For them, you will go for ovulation induction. So, initiation of therapy, generally you will go for HMG. HMG, that is Menopure or Mariofert is the drug trade names. Okay. So, these can be given 75 international units daily. Daily, they will take 75 international units. Then they will give IM. Okay. So, day 10 to day 12, generally day 10 to day 12 of initiation of therapy, you will assess the follicles. If no follicle is more like more than 10 mm, no number of follicles will be there. If no follicle is more than 10 mm, that means it is not reacting. So you'll continue to dose of HMG for 5 more days, and again you'll reassess. Again you'll reassess, and if 2 follicles are more than 14, okay, more than 14, 2 follicles are more than 14, then you'll go for trigger. For ovulation, for oocyte rupture, you'll give a trigger, that is HCG. 5000 international units HCG you'll give. After trigger, day 7 after trigger, you'll measure the serum progesterone. If serum progesterone, if levels are more than 30, serum progesterone levels are more than that with 30 nanomoles per liter. That means ovulation is confirmed, pakka. Day 14 to 80, you will go for blood beta HCG or UPT test. You will confirm the pregnancy. If there is negative, beta HCG is also normal and UPT is also negative, and there is no pregnancy, then you go for withdrawal bleeding and you'll go for after day 2 of next cycle, next bleeding, like the day when she started bleeding, on the day 2, you'll go for initiation of next ovulation induction. Okay. So if no follicular development is seen even after this HMG and all that HMG trigger and HCG trigger and all that, there is no ovulation or there is no follicular development, then you should go for clinical review of this patient. Okay. So after with great struggle, this couple got pregnant. So how to monitor her? How to do antenatal care? So until pregnancy, you will monitor both the pair partners, whether he have thalassemia or she have thalassemia. Once she got pregnancy, antenatal care is very important. So pregnant patient who are transfusion dependent, from the childhood they are having blood transfusion, for them you will go for cardiac T2 scan. If it is more than 20, I already told, more than 20 means good. No, so they prior to conception they require specialist cardiac assessment. Okay, they should go for cardiac assessment also. And ejection fraction should be more than 56%. That is also very important. So whatever the features are, they should go for cardiac assessment. Early in third trimester also they should go for to cardiologist. Okay, the pregnant patient should monitor thyroid function with thalassemia because hypothyroidism is seen, very important. They'll confuse this with the option. Whenever you have double kind of things like hyper, then they'll confuse you in the options that hyperthyroidism in thalassemia. No, hypo is in thalassemia. You will monitor the serum fructosamine in pregnancy patients with thalassemia and diabetes. How? What is the interval? You monitor monthly. HbA1c generally you will go for 3 monthly, right? But here fructosamine is you will monitor monthly. Okay, you'll initiate folic acid 5 milligram preconceptionally and continue throughout the pregnancy. That's also important. Initiate aspirin daily from 12 weeks. Viability scan at 7 to 9 weeks. You will go for viability that for that cardiac activity thing, and growth scan every 4 weeks from 24 weeks. 4. Okay, remember 4. Thalassemia 4. 4 weekly from 24 weeks. Okay. And at third trimester, you should go for anesthetic assessment also. Okay, maybe she may land in cesarean, but thalassemia is not a indication for cesarean. But if she may land in cesarean, then anesthetic assessment should be present. Patient who are splenectomized or okay important or the platelets are more than 6. This one has been changed in recent guidelines. Okay, splenectomized or platelets is more than 60 matlab 600 into 10 power 9. For them, in them you will go for low molecular heparin, also aspirin, both you will give. Okay, generally before it was like splenectomy plus platelets both should be present, and you'll give both. No, in now it has been given that if she's splenectomized also you'll give both. If the platelets are more than 600 also you'll give both. Okay, and 28 weeks onwards you'll go for low-molecular heparin up to 6 weeks postpartum and throughout the pregnancy. And all pregnant patients with thalassemia require low-molecular heparin during hospital admission. If thalassemia patient admitted in hospital, we will give low-molecular heparin. Remember that. So this is very important. TTD means transfusion dependent thalassemia. For transfusion dependent thalassemia, the target of hemoglobin should be 10 gram %. Okay. For non-transfusion dependent thalassemia, the hemoglobin target should be 12 gram. Okay. Pre-transfusion, it should be maintained at 10. But after transfusion, post-transfusion, the hemoglobin should be 12. Okay. Coming to non-transfusion dependent, untransfused. Transfusion can be avoided before delivery. Hemoglobin it is more than 8 at 36 weeks. You'll at the see at 36 weeks a lady came, pregnant lady came. She's 36 weeks. Hemoglobin is 8 or 9. Remember like that. Okay. At that time, you should keep at least 1 to 2 units of blood at 37 to 38 weeks. If the hemoglobin is less than 8, like 7 or something, then you should keep at least 2 units of blood in the labor room. Okay. Postnatally also you can transfuse if necessary only. Okay. Remember that. So transfusion dependent, target is 10. Non-transfusion dependent, pre-transfusion is 10. Post-transfusion should be 12. That is important. This is the same thing which I discussed. Yeah. Transfusion dependent patients are there, transfusion dependent patients of thalassemia. So because they have multiple transfusions, there will be iron overload burden. Cardiac function should be scanned. There is no scans in the 12 months prior to conception, and myocardial iron loading should be undergo regular cardiology review with careful monitoring of ejection fraction should be done. And patients with no myocardial iron loading should be assessed in early third trimester to plan the delivery. Okay. Palpitations, if they are present in thalassemia, they should assess for arrhythmias. And women with high risk of cardiac decompensation should commence low dose subcutaneous desferoxamine. Desferoxamine should be given 20 milligram per kg body weight on a minimum of 4 to 5 days a week. If cardiac decompensation you are feeling, you should chelate her. Okay. And cardiology guidance should also be done there at 20 to 24 weeks. So this is the thing which I already told. If there is severe myocardial iron overloading, you'll go for desferoxamine, 20 milligram per kg body weight, and cardiac decompensation is there. Then you can go for IV, consider optimal dose of 40 to 50. Severe hepatic loading is there, then low dose chelation can be done. Okay. Coming to transfusion dependent patients, indications for chelation. I already told severe myocardial overloading, cardiac decompensation, severe hepatic overloading, then you can chelate. Okay, generally from 20 weeks of gestation. So this is the schedule for antenatal care. So first a lady came who is pregnant and she's thalassemia, major. Okay, then you'll review the patient results and discuss the prenatal diagnosis. If she has high risk of diabetes, so you refer her to diabetic antenatal team. You'll assess the endocrine, hepatic, cardiac status preconceptionally. So you review if she's having multiple transfusions since childhood, then you'll go for cardiac, liver iron, ejection fraction. These should be done at least 12 months prior to conception. Echo it should be done. Okay, cardiac MRA is done. The T2 scan is there, that is MRA only. Abdominal ultrasound for spleen, liver, gallstones is done. Baseline CBC, renal function, LFT, urine protein creatinine ratio, ferritin, B12, folate, blood is done. Is seen. Grouping cross matching, red cell typing, extended genotyping is also done if not done already. We'll go for thyroid function test in each trimester. Generally antenatal care guidelines don't recommend thyroid function test, don't recommend LFT, RFT, but thalassemia patient we should go for this. Okay. VD risk assessment, splenectomy is high risk. You will prescribe 75 to 150 milligram aspirin. Discuss vaccinations like pneumococcus, influenza, COVID vaccine, Haemophilus type B, meningococcal vaccine, types also there. You'll discuss HPV vaccine if not immunized. Penicillin prophylaxis is given 250 milligram BD. If she's allergic, you go for erythropoiesis. So what are the different scans? And we already know 7 to 9 weeks you'll go for dating scan, that is viability scan. Then 10 to 14 weeks is first trimester scan. And from 24 weeks onwards, you'll go for 4-weekly scan. You'll deliver at 38 weeks if she's diabetic. If she's diabetic, you'll go for delivery at 38 weeks. If it's okay, all normal, then you can deliver after 41 weeks. Intrapartum care, generally senior midwife, obstetrician, anesthetics, hematologist should be informed. Hemoglobin, if less than 10, red cell antibodies typing is very important. Cross matching should be done. You should save the sample. In case of transfusion dependent patients, during labor, throughout the labor, you'll give desferoxamine 2 gram over 24 hours. So you give 2 gram desferoxamine over 24 hours, full day you'll give desferoxamine. And continuous, as thalassemia is a risk one, you will go for continuous CTG. Thalassemia is not indication for cesarean, which I already told. So active management of third stage of labor, AMTSL should be done to minimize the blood loss. So this is a postpartum care. So formal postnatal assessment of iron overload should be done. Chelation can optimize the iron burden if iron is more than 5. Okay, chelation should be discussed with the patient. Patient can go for breastfeeding as well. During breastfeeding, you can continue this chelation infusion after labor. Okay, 40 to 60 milligram per kg per day subcutaneously on a day 5 or a week. By 6 weeks postpartum can be given. If she's not breastfeeding, okay, then you can go for IV or subcutaneous until discharge. Okay, routine postnatal care should follow national guidelines. Breastfeeding should be encouraged. Desferoxamine goes in breast milk, but it is not absorbed in the baby. Okay. Spectrumized patient, which I already told, they should receive low molecular heparin 6 weeks delivery. After delivery, assess the iron burden at 3 months postpartum until myocardial iron overload necessitates early. And consider prescribing estrogen only HRT at low doses to support breastfeeding in hypogonadal patient. Oh, if a patient who is hypogonadal, she got pregnant and she delivered, so you should go for estrogen only HRT for this patient because breastfeeding will be supported by means of this. Okay. So lactation is a physiological state. So patient with profound hypogonadism and undetectable levels of postpartum may struggle to breastfeed. So estradiol only HRT at very low dose is given. For example, 25 milligram patches are given. If hypogonadal patient or delivered, you will go for estradiol only HRT, mainly which supports the breastfeeding. So a 25-year-old transfusion-dependent beta thalassemia has been trying to conceive and undergoing ovulation induction. Which of the following statement is true regarding the regards to young women with beta thalassemia major? So basically, diabetes is most common endocrinopathy complication. No. What is the most common endocrine? Pituitary complication. Hyperthyroidism is non-complication? No. Hypothyroidism. Desferoxamine can be safely used throughout the pregnancy? No. Second and third trimester only. Cardiac failure is the primary cause of death in 50% of cases. This is the one. Okay. So this is the thing about thalassemia in pregnancy. So I hope you understood. If you want, if any doubts, please ask me. Thank you.